Next, let's see about purulent uveitis. Purulent uveitis separate inflammation of the uveal tract occurring as a result of direct invasion by pathogenic organisms. It may start as iridocyclitis or choroiditis, which is purulent posterior uveitis, which soon progress to involve retina and vitreous, resulting in purulent endophthalmitis and ultimately leading to panophthalmitis. Endophthalmitis defined as an inflammation of inner structures of eyeball, that is uveal tissue and retina, associated with pouring of exudates in vitreous cavity, anterior chamber and posterior chamber. Pouring of exudates into vitreous cavity, anterior chamber and posterior chamber. Etiology endophthalmitis may be infectious, non-infectious. Modes of infection: exogenous infection. Purulent inflammation are generally caused by exogenous infections followed by perforating injuries, perforation of infected corneal ulcers, or as post-operative infections following intraocular operations. Endogenous metastatic endophthalmitis. It may occur rarely through bloodstream from some infected focus in the body, such as caries teeth, generalized septicemia, purpura septis, secondary infection from surrounding structures. It is very rare. However, cases of purulent intraocular inflammation have been reported following extension of infection from orbital cellulitis, thrombophlebitis, and infected corneal ulcers. Causative organisms: Staphylococcus epidermis, Staphylococcus aureus, Streptococcus, Pseudomonas, Pneumococci, Corynebacterium, etc. Propionibacterium acnes and actinomyces are gram-positive organisms capable of producing slow-grade endophthalmitis. Fungal endophthalmitis is comparatively rare. It is caused by Aspergillus fusarium candida. Next is non-infectious endophthalmitis. It occurs in following situations: post-operative sterile endophthalmitis. It may occur as toxic reaction to chemicals adherent to intraocular lens or chemical adherent to instruments. Severe reaction mainly confined to anterior segment is known as TASS, toxic anterior segment syndrome. Next is post-traumatic sterile endophthalmitis may occur as toxic reaction to retained intraocular foreign body, example pure copper. Phacoanaphylactic endophthalmitis may be induced by lens proteins in patients with Morganian cataract. Intraocular tumor necrosis may present as sterile endophthalmitis. Clinical feature of acute bacterial endophthalmitis. It is a catastrophic complication of intraocular surgery with incidence of about 0.1%. Source of infection: in most of the cases is thought to be patient's own periocular bacterial flora of eyelids, conjunctiva, and lacrimal sac. Other potential sources of infection include contaminated solutions, instruments, and environmental flora, including that of surgeon, operating room personnel. Onset may be acute or delayed. Acute onset usually occurs between 1 to 7 days. Delayed onset occurs for a week. Fungi are most common cause. Propionibacterium acne is second most common cause. Symptoms: is characterized by severe ocular pain, redness, lacrimation, photophobia, etc. Lids become red and swollen, and conjunctiva shows chemosis, marked circumcorneal congestion. Cornea is edematous, cloudy, and ring infiltration may be formed. Edges of wound become yellow, necrotic, and wound may gape. 8.19. Severe post-operative endophthalmitis with wound gape. Anterior chamber shows hypopyon. Soon it becomes full of pus. Iris when visibly edematous and muddy. Pupil shows yellow reflex due to purulent exudates in vitreous. Then vitreous exudation in metastatic forms and in cases with deep infections. Vitreous cavity is filled with exudation and pus. Soon a yellowish white mass is seen through fixed dilated pupil. The sign is called amuretic cat-eye reflex. Intraocular pressure is raised in early stages, but in severe cases the ciliary processes are destroyed. Treatment: an early diagnosis and vigorous therapy is hallmark of treatment of endophthalmitis. Then antibiotic therapy, intravitreal antibiotics and diagnostic tap should be made as early as possible. It is performed transconjunctively under topical anesthesia from the area of pars plana, 4.5 mm from limbus. The vitreous tap is made using 23 gauge needle followed by intravitreal injection using disposable tuberculin syringe and 30 gauge needle. Mainstay of treatment is intravitreal injection of antibiotics at early earliest possible. Usually combination of two antibiotics, one affecting gram positive coagulation negative staphylococci and other against gram negative bacilli. First choice vancomycin, then ceftazidime, then second choice is vancomycin and amikacin. The aspirated fluid sample from vitreous cavity should be used for bacterial culture and smear examination. Then second is topical concentrated antibiotics should be started immediately and used frequently every 30 minutes to 1 hour. To begin with, a combination of two drugs should be preferred, one having predominant effect on gram positive organism and other against gram negative organisms. Vancomycin, cefazolin, amikacin, tobramycin. Then systemic antibiotics have limited role in management of endophthalmitis, but most of the surgeons do use them. Ciprofloxacin intravenous infusion 200 mg BD for 3 to 4 days, followed by orally 500 mg BD for 6 to 7 days. Vancomycin, cefazolin, steroid therapy. Most surgeons recommend their use after 24 to 48 hours of control of infection by intensive antibiotic therapy. Intravitreal injection of dexamethasone 0.4 mg in 0.1 ml along with antibiotics. Next is topical dexamethasone, predacetate. Systemic steroid should also be given. Lansoprazole 30 mg OD. Supportive treatment cycloplegic, preferably 1% atropine or 2% homatropine. Anti-glaucoma drugs, acetazolamide, timolol, etc. may also be preferred. Vitrectomy operation should be performed if patient does not improve with above intensive therapy for 48 to 72 hours. Vitrectomy helps in removal of infecting organisms, toxins, enzymes present in infectious vitreous mass. Panophthalmitis. It is an intense purulent inflammation of whole eyeball including Tenon's capsule. The disease usually begins either as purulent anterior or purulent posterior uveitis, following through very short stage of endophthalmitis. Panophthalmitis is acute bacterial infection. Mode of infection, causative organs are same. Then clinical features: severe pain, headache, loss of vision, profuse watering, purulent discharge, marked redness and swelling of eyes. Signs are as follows: lid shows marked edema and hyperemia. Eyeball is slightly proptosed. Ocular movements are limited and painful. Conjunctiva shows marked ecchymosis, ciliary, as well as conjunctival congestion. Cornea is cloudy and edematous. Anterior chamber is full of pus. Vision is completely lost and perception of light is absent. Intraocular pressure is markedly raised. Globe perforation may occur at limbus. Pus out and intraocular pressure fall. Complications include orbital cellulitis, cavernous sinus thrombosis, meningitis and encephalitis. Treatment: there is little hope of saving such an eye, and the pain and toxemia lend an urgency to removal. Anti-inflammatory and analgesic broad spectrum antibiotics evisceration process should be done to avoid risk of intracranial dissemination and meningitis. Evisceration is the removal of contents of eyeball leaving behind the sclera. It's panophthalmitis. It is only about 3 mm frill of sclera is left around the optic nerve. These include panophthalmitis, expulsive choroidal hemorrhage, bleeding, anterior staphyloma. Surgical steps of full evisceration. Initial steps up to separation of conjunctiva and Tenon's capsule are similar to enucleation. Removal of cornea. A cut at the limbus is made with razor blade fragment or with a number 11 scalpel. Removal of intraocular contents. Uveal tissue is separated from sclera with help of an evisceration spatula, and contents are scooped out using curate, and separation of extraocular muscle is done. Removal of sclera. 3 mm frill around the optic nerve, it's left behind and the remaining is removed. Closure of Tenon's capsule and conjunctiva are final steps. Degenerative condition of uveal tract. Simple iris atrophy, essential iris atrophy. It is depigmentation with thinning of iris stroma. Small patches of depigmentation are usually seen near pupillary margin. Differential diagnosis of patch of simple iris atrophy may be senile atrophy, post-inflammatory glaucomatous, or neurogenic due to lesions of ciliary ganglion. Essential iris atrophy is a rare idiopathic condition characterized by unilateral progressive atrophy of iris. Affects young females. Initially, there occurs displacement of pupil away from atropic zone. Slowly, iris tissue melts away at many places, resulting in pseudopolychoria. Intractable glaucoma supervenes due to formation of dense anterior peripheral synechiae. It is a rare iridocysis or rare bilateral atrophy occurring senile degeneration in patient over 65 years. It may also occur later affect iris trauma. Then degeneration and dystrophies of choroid. Primary choroidal degeneration, senile central choroid atrophy, central areolar choroid atrophy, essential gyrate atrophy, choroidemia. Characterized by yellow spot. These are scattered through fundus. It comprises a bilateral puncture out circular atrophic lesion in macular area. Transverse large ripple-shaped choroidal vessels. Inborn error of amino acid metabolism characteristic progressive patches of atrophy of choroid and retinal pigment epithelium. It is a hereditary choroidal dystrophy involving males. Lesions progress slowly. By the age of 40, almost all of choroidal tissue or P disappear. Secondary degeneration also there. Ophthalmic picture resemble retinitis pigmentosa, hence also named as pseudo retinitis pigmentosa. Then tumors of uveal tract. The classification are tumors of choroid, benign and nevus. Hemangioma, melanocytoma, choroidal osteoma. B is malignant, it is melanoma. Tumors of ciliary body, benign hyperplasia, benign cyst, medullopithelioma, malignant melanoma. Tumors of iris, benign nevus, benign cyst, nevus-xanthoendothelioma and malignant melanoma. Nevus, it is commonly occurring asymptomatic lesion, usually diagnosed on routine fundus examination. It typically presents as flat dark grey lesion with featured margins, usually associated with overlying colloid bodies. Once diagnosed, it should be followed regularly since it may undergo malignant change, and which is evidenced by increasing pigmentation or height of nevus, appearance of orange patches of lipofuscin over the surface, appearance of serous detachment in the area of nevus. Choroidal hemangioma, it occurs in two forms. Localized choroidal hemangioma, it presents as raised dome-shaped salmon pink swelling, usually situated at posterior pole of the overlying retina, may show serous detachment, cystoid degeneration, pigment epithelial mottling. Fluorescein angiography is usually diagnostic. Diffuse choroidal hemangioma, it is seen in associated with Sturge-Weaver syndrome. Melanocytoma is rare tumor. Choroidal osteoma, it is very benign tumor which presents as elevated yellowish orange lesion in posterior pole. It typically affects women. Malignant melanoma of choroid, it is most common, primarily intraocular tumor of adults, is usually seen in 40 to 70 years. It is rare in blacks, comparatively more common in whites. It arises from neural crest derived pigmental cells of UVEA as a solitary tumor and is usually unilateral. Pathology. The tumor may arise from a pre-existing nevus or de novo from the mature melanocyte present in stroma. It may occur in two forms: circumscribed tumor, diffuse malignant melanoma. Circumscribed tumor, initially it appears as flat slate grey area which becomes raised, pigmented with growth, eventually ruptures through Bruch's membrane, called a stud tumor. Further growth of tumor produce exudative retinal detachment. Second one, diffuse, it spreads slowly through UVEA without forming a tumor. It accounts for only 5% cases. Symptoms occur late. Histopathology, microscopically uveal melanomas are of following four types. Spindle cell melanomas, these are composed of spindle shaped cells, make up 45% of all tumors. Epithelial cell melanomas, these consist of large oval or round pleomorphic cells with larger nuclei and abundant acidophilic cytoplasm. This type of tumors have the worst prognosis, 35% 10-year survival. These make up 5% of all tumors. Mixed cell melanoma, these are composed of both spindle and epithelial cells. Necrotic melanoma, these make up remaining 5% of all tumors. Clinical features. For the purpose of description, only clinical features can be divided into 4 stages: quiescent stage, glaucoma stage of extraocular extension. Okay. Quiescent stage. During this stage, symptoms depend upon location and size of tumors. Small tumor located in periphery may not produce any symptom, while tumors arising from posterior pole present with early visual loss. A large tumor associated with exudative retinal detachment may produce marked loss of vision. Signs: fundus examination during this stage may reveal following signs. Small tumor limited to choroid appears as an elevated pigmental oval mass. Rarely tumor may amelanotic. The earliest pathognomic sign at this stage is appearance of orange patches in pigment epithelium due to accumulation of lipofuscin pigment. Large tumor which penetrates through Bruch's membrane and grows in subretinal space is characterized by a large exudative retinal detachment. Malignant melanoma of choroid causing exudative retinal detachment. Diagrammatic depiction in cut section. Fundus photography. Extensive malignant melanoma of choroid involving orbit. At the central summit, the retina is in contact with tumor. Ribbon-like white vessels are seen coursing over the tumor surface of the area. Other associated features which can be seen occasionally include subretinal or intraretinal hemorrhage, choroidal folds, and vitreous hemorrhage. As the tumor grows, the exudative retinal detachment deepens and gradually the tumor fills the villi. Next is glaucoma stage. It develops when tumor is left untreated during quiescent stage. Glaucoma may develop due to obstruction of venous flow by pressure on vortex veins. These veins supply 75% of the choroid. Blockage of the angle of anterior chamber by forward displacement of lens iris diaphragm due to increasing growth of tumor. Symptoms: patient complaints or presents with severe pain, redness, watering in an already blind eye. Signs: conjunctivitis, chemosed and congested. Cornea may show edema. Anterior chamber is usually shallow. Pupil is fixed and dilated. Lens is usually opaque, obstructing the back view. Intraocular pressure is raised and usually eye is stony hard. Sometimes features of iridocyclitis may be seen due to tumor-induced uveitis. Stage of extraocular extension. See, fundus photography showing choroidal melanomas, raised pigmented subretinal mass. Then stage of extraocular extension. Due to progressive growth, tumor may burst through sclera, usually at the limbus. The extraocular spread may occur even early along the perivascular space of the vortex vein and or ciliary vessels. It is followed by rapid fungation and involvement of extraocular tissue, resulting in marked proptosis. Stage of distant metastasis. Lymphatic spread is usually not known. Blood-borne metastasis usually occurs in liver and is commonest cause of death. Differential diagnosis. During quiescent stage, a small tumor without an overlying exudate retinal detachment should be differentiated from nevus, melanocytoma, and hyperplasia of pigment epithelium. Tumor with overlying exudate retinal detachment should differentiate from simple retinal detachment and other cases of exudative detachment, especially choroidal hemangioma and secondary deposits. During glaucoma stage, differentiation is to be made from other causes of acute glaucoma. Investigation: indirect ophthalmoscopic examination, transillumination test, ultrasonography, fluorescent angiography, radioactive tracer, A scan, B scan done. B scan of patient with choroidal melanoma showing dome-shaped tumor. This tumor mass and thus helps to differentiate from choroidal detachment, simple retinal detachment. Indirect ophthalmoscopic examination, it allows three-dimensional stereoscopic view of lesion. Treatment: observation. When diagnosis is doubtful, observation is indicated especially for small asymptomatic lesion with absence of suspicious features. Conservative treatment to salvage the eyeball should be instituted when there is no doubt of diagnosis. Tumor is not very large. Brachytherapy using cobalt 60 or iodine 125 plaques surgically placed externally on sclera is usually treatment of choice in tumors less than 10 mm elevation and less than 16 mm in basal diameter. Supplemental transpupillary chemotherapy also should be required. External beam radiography done for tumors unsuitable for brachytherapy. Transpupillary thermotherapy (TTT) diode laser is indicated in small Selected small tumors located, and if pigmented located near fovea or optic disc. Transcleral local resection is indicated in tumors that are too thick for radiotherapy, usually less than 16 diameter. Stereotactic radiosurgery is a new method indicated in large tumors. It involves single session delivery of ionizing radiation to stereotactically localized volume of tissue with help of gamma knife. Enucleation, it is indicated for very large tumors greater than 16 basal diameter or greater than 10 apical height, in which conservative methods to salvage the eyeball are not effective. Excenteration or debulking, it is also done with chemotherapy and radiotherapy. Palliative treatment with chemotherapy and immunotherapy may be of some use in prolonging life of patient with distant metastasis. Prognostic indicators: age of patient, size of tumor, location of tumor, evidence of inflammation, cell type, cytology, chromosomal abnormalities, etc. Tubers of ciliary body. Hyperplasia and benign cyst, medulloepithelium dictyoma, congenital arising from non-pigmented epithelium of ciliary body, congenital tumor, malignant melanoma. In ciliary body, it is usually diagnosed very late due to its hidden location. Clinical features: early features of localized melanoma include slight hypotony, unaccountable defective vision, localized sentinel dilated episcleral vessels, and anterior spreading tumor may present as follows. It may cause pressure on lens resulting in anterior displacement, subluxation, cataract formation. It may involve iris and is visible immediately. Soon it may involve angle of anterior chamber resulting in secondary glaucoma. It may extend out through sclera along the vessels, presenting as epibulbar mass. Posterior spreading tumor may involve choroid and present as exudative retinal detachment. Pathological features: these are similar to that of choroidal melanoma. Enucleation: it is required for large ciliary body tumors extending anteriorly, posteriorly, circumferentially. Local resection, cyclectomy, iridocyclotomy. Tumors of iris, naivozanthoendothelioma, and malignant melanoma. It is present as single or multiple rapidly growing vascular nodules. It may penetrate through limbus and present as epibulbar mass. Pathological features are similar to that of melanoma of choroid. Treatment: wide iridectomy, iridocyclectomy, enucleation. Okay, next chapter we will see about diseases of lens.